Our next topic is eating disorders. DSM-5 categorizes eating disorder into three main groups: anorexia nervosa, bulimia nervosa, and binge eating disorders. We will take a look at the difference between each of these, and as a summary, I have put the most important diagnostic criteria in these boxes. So we will go through the summary first before going through each of these disorders. Anorexia nervosa patients are really thin. They have very low BMI, but they have intense fear of weight gain. If someone tells them you are thin, they will not accept that. They will keep thinking they are fat and they need to lose weight. They have distorted view of body weight and shape. Bulimia patients, they have a normal BMI, but they have excess worry about the body shape and weight, and unlike normal people, they have inappropriate compensatory behavior, similar to what you get in anorexia nervosa. The difference between anorexia nervosa and bulimia nervosa in terms of case presentation is that they will have binge eating episodes. So they will order maybe 4 extra large pizzas and eat them all themselves. Now, it's important to know that they won't have this behavior in front of others. When they are outside with their friends, they would have a normal meal. But when they go back home, they will have hordes of candy or anything hidden for them to eat once they go back. What are the differences here? What are these compensatory behavior that we see in anorexia and bulimia? There can be purging. There can be abuse of diuretics, most commonly furosemide, a loop diuretic, then laxatives, then diet, exercise. So diet and exercise seems a normal response that most people would have. But these people go overboard. They would try crazy diets, maybe 1 sandwich a day. They would try crazy exercise, maybe 3 hours of exercise every day, 5 times a week. A normal person would exercise, let's say, 3 times a week for 1 hour. But this is important to know. Binge eating disorder is something a lot of people would have. They have binge eating episodes without any compensatory behavior. Let's take a look at anorexia nervosa first. We have a 25-year-old woman who presents to the clinic due to irregular menstrual symptoms. Now, the reason I put this here is to tell that DSM-4 used to include irregular menstrual symptoms under a diagnostic criteria for anorexia. But in DSM-5, they have removed that. She's sexually active with one partner and uses contraceptives. She states that she has recently been feeling a lot of stress and anxiety, believing that her partner no longer finds her attractive because of weight gain. She also informs the physician that she overindulges on fast food during episodes of stress and vomits it out afterwards. This seems to be sort of a binging behavior. Could it be bulimia nervosa? Let's take a look at this. Her BMI is very low. Bulimia patients will have normal BMI. Her heart rate is regular without murmurs and urine HCG is negative. She's not pregnant. This is anorexia nervosa, binge, purge, subtype. We will talk about these subtypes. But basically, she's vomiting out the food that she's eating. Like I said, bulimia patients have normal or increased weight gain. And anorexia patients are always underweight. And obviously, this is more common in young women. Signs and symptoms: when there's no fat in their body, they will have increased sensitivity to cold, dizziness, syncope. There's low sugar, amenorrhea, lack of sexual interest, poor sleep-wake cycles, bradycardia, hypotension, cardiac arrhythmias. Reason is, when you vomit, you are losing a lot of potassium ions, and this could be fatal. Peripheral edema and cavities. This is with purging. Then there's also esophageal symptoms, such as increased risk of Mallory-Weiss syndrome. And then investigations. You can test for FSH, TSH levels. This is for menstrual abnormalities. TSH levels to see why there is the low BMI. Increased cortisol levels, low blood sugar levels. Hypokalemia. When they use when they use laxatives, there will be decreased gut motility. Anemia, hypercholesterolemia, electrolyte imbalances, dehydration. These subtypes. So like I said, some patients would go on crazy diets, go on exercise. Some patients would abuse laxatives, purge them, so etc. So this falls under restricting type. And this behavior falls under purging type. So these people would eat a lot at once, worries about getting fat, and will have purging behavior such as laxatives, vomiting, diuretics. And there's something called the Russell's sign. So these patients would put their hand in to the back of their mouth to induce vomiting. And when this happens, their fingers will scrape against the teeth, leading to abrasions and calluses on the back of the hand overlying the knuckles. On top of the knuckles, on the back of the hand, there will be calluses and abrasions. And also, because there's a lot of acid coming out, there are a lot of dental erosions seen. In restricting type, they have diets, fasting, and exercising, over-exercising. There's some emergency which is called the refeeding syndrome. So after a long time of malnourishment, if these patients are suddenly given carbohydrate-rich diets, there will be a rapid rise in insulin. This will decrease potassium levels in the blood. This can cause heart problems. And also, there can be seizures and rhabdomyolysis. So some indications for patient care: if the BMI is very low, if the temperature is really low, heart-related symptoms, low blood pressure, postural hypertension, arrhythmias, all of these are indications for hospitalizing the patient. And the treatment is 3 things: nutritional rehabilitation, cognitive behavioral therapy, and pharmacological treatment. Why do we give these SSRIs? They don't need it. We give it to induce weight gain. And very important, there's a drug which we will learn. It's called bupropion, which is contraindicated in these patients because there is an increased risk of developing seizures. This is usually used, we will learn about this. One of these uses is to help people quit smoking. Next, let's take a look at bulimia nervosa. This is more common in young women who were once obese. So they were once obese and they grew thin and are now afraid of growing fat again. But these patients will usually have recurrent episodes of overeating. And then once they are done eating, they will feel a sense of loss of control, that they have lost control. So then they need to take extreme measures to control their body weight including compensatory behaviors, at least weekly. This is called compensatory behavior. Periods of starvation, purging, excess exercise over the last 3 months. The BMI will be normal or slightly overweight. These patients do not need to be hospitalized. Vomiting behavior is associated with a lot of problems. Electrolyte disturbances, Mallory-Weiss syndrome, this is a problem of the esophagus, myopathies, enamel erosion, all of these. Menstrual irregularities, no longer classified under DSM-5. Laxative side effects, hyponatremia, chronic constipation, and it is associated with borderline personality disorder. We will learn about this under personality disorders. The treatment is the same as above: cognitive behavioral therapy, nutritional rehabilitation, and antidepressants. Topiramate can be used to suppress binge eating, but in the exam, fluoxetine is the most effective medicine which is used. And again, bupropion is contraindicated due to the seizure risk. Next, binge eating disorders. Recurrent episodes of binge eating without any compensatory behavior. So basically, this is most of the people. And the diagnosis must be at least weekly over the last 3 months. There's obviously an increased diabetes risk and is the most common eating disorder in adults. They eat, they are worried, okay, I'm growing fat, but they don't do anything crazy to try to reduce this. That's the difference between the other two. The treatment for this is cognitive behavioral therapy, behavioral weight loss therapy, SSRIs, and a drug called lisdexamfetamines, which is also used to treat ADHD. Amphetamines, we will learn this under ADHD. These are stimulants. And then we have a disorder called Pica. This is when you eat non-food substances for 1 month or more that is not recognized as normal. This helps them feel emotional relief. This is seen in children and during pregnancy. The most commonly eaten substance is ice. Then there could be dirt, clay, etc. And very importantly, it's associated with iron deficiency anemia. Patients who are deficient in any iron will usually show Pica symptoms: developmental abnormalities, emotional trauma, and malnutrition. When you don't have something to eat, you eat whatever you find. Treatment: nutritional rehabilitation and psychotherapy. If it doesn't work, SSRIs. Let's start the case study. A 27-year-old business graduate student comes to the physician for a routine physical examination. Medical history reveals no problems except for a recent history of bulimia. The patient has smoked a pack of cigarettes daily for the past 7 years. He tried quitting smoking but did not succeed. He is not on any medication. At the end of the visit, he asks for assistance with smoking cessation. In addition to counseling, which of the following would have the greater risk of side effects if prescribed to help him quit smoking? Now, I put this question because there are two drugs which sound very similar. And the answer for this is bupropion should not be prescribed to a patient with a history of bulimia. Busiperon is used to treat generalized anxiety disorder. This is used to help smoking cessation. We will talk about this later, but because this patient has a recent history of bulimia, we do not give this patient this drug. A 23-year-old woman comes to the office due to weight gain. The patient has gained 10 pounds since losing her old job and starting a stressful job 4 months ago. She says, "I hate the way I look. I try to limit my portions, but several times a week, I end up eating a whole bag of chips or a quart of ice cream in one sitting, even if I'm not hungry. My stomach is so bloated that I cannot fit into any of my clothes. It's so depressing. The person has had abdominal discomfort without nausea or vomiting. Her weight is always fluctuating, although she has tried numerous diets over the past few months. She does 45 minutes of aerobic exercises 12 times a week. There are 7 days in a week. The patient prefers to eat alone because she feels embarrassed and out of control. She feels guilty about her behavior and her self-esteem is low. BMI is normal. Which of the following is the most likely diagnosis? It's not an adjustment disorder. She feels she's doing something about her situation. She has body dysmorphic symptoms. But the answer is Bulimia Nervosa. A 25-year-old woman comes to the office due to recent weight gain. She has eaten more than usual over the last 4 months, has gained 3.2 kilos, and feels guilty and depressed about it. Further questioning reveals she consumes a large pizza and 4 large bags of chips several times a week. Afterwards, the patient feels ashamed of losing control and fasts to make up for it. She is very distressed about being unable to lose weight despite exercising 2 to 3 hours a day. BMI is 23.7. Despite telling the patient she has a normal BMI, the person insists that she is overweight. The back of the patient's hand appears to be calloused. She also complains of throat pain. What this is she didn't tell the doctor that she has purging behavior. So this is very common. They will tell things like, okay, I would exercise, but they would leave out things such as the purging behavior. So it's on physical examination, you can usually see these. There is low potassium, another indicator. Which of the following is the most likely diagnosis? Not this. BMI is normal. Binge eating disorder. She has binges, but she feels guilty about it. Body dysmorphic disorder. Bulimia Nervosa. A 23-year-old woman comes to the office due to concerns about her weight. She feels annoyed about gaining weight despite maintaining a well-balanced diet and exercises for an hour 3 times a week. This is normal. The patient has been worried for years that her arms are huge and her thighs are too thick. She always wears loose-fitting pants and spends hours a day researching leg exercises and measuring the circumference of her thighs. This is not normal. She weighs 58 kilos and is 170 meters tall. Her BMI is normal. Which of the following is the most likely diagnosis? It is not normal behavior. Her BMI is normal. And this is not bulimia nervosa. This is body dysmorphic disorder. BDD is when there is a fixation on a perceived defect in appearance that is not apparent to others. The other people will see it as normal, but then the patient would think that they look ugly, usually due to 1 or 2 body parts. They will have excess mirror checking, grooming, comparing with others, and looking up on the internet, all these kinds of behavior. This also causes significant distress, as we can see in this case. She has been worried about this for years. Final question. A 20-year-old woman, Gravida 2, Para 0, comes to the office for a prenatal visit at 16 weeks of gestation. The patient has not gained weight since her last visit 4 weeks ago. Has occasional nausea with vomiting twice a week. She has little appetite, which she attributes to mild indigestion, and her food consumption has decreased. However, the patient craves ice, not ice cream, ice, and has been consuming it throughout the day for the last few months. Medication includes prenatal vitamins. She was prescribed twice daily iron for anemia, but does not take it because it causes constipation. She has no diarrhea, dysuria, chills, or fever. Uterus fundus is normal. Which of the following is the most likely diagnosis? Eating what you shouldn't eat. Pica.